a subject of tuberculosis. This disease is known by varied names, and the organism that is causative of this has been variously described as a scourge or curse to mankind. And truly so, because if an organism can challenge us for over 7,000 years, it has to reinvent itself, and it has to keep on advancing in order to trouble us and torment us over centuries and centuries. So I'm going to share some of my experiences in treating these patients. So the worldwide incidence has constantly been increasing. From 2.3 million, there was a 25% increase to 2.9 million, and India takes the cake. We get the maximum number of tuberculosis patients, and the incidence from Mumbai city has been reported as 65,000 annually. Given that 5% of these patients have spinal tuberculosis, we can calculate that roughly about 3,000 plus patients of tuberculosis are detected every year, and that is sufficient number to keep all of us on our toes. Now, if this X-ray was presented to any one of us, the action to be taken would depend upon the time frame in which the X-ray was presented. So, given the till the 80s and early 90s, when MRI was not available, very few reports on drug resistance, and it was not considered a very serious problem. The attitude was very simple, like this motorcycle advertisement, that 4-drug AKT was started, and including injection streptomycin, and the case was done with, because most of them united to my knowledge and these were the things when I was a resident. A decade later, when this X-ray would come, there was a scare and there was a fear of drug-resistant tuberculosis, and although MRI was available, the trend towards biopsy was still minimal, and culture was also was introduced in 1995. A decade later, 21st century, first decade, second half, the second decade, there was a real scare and a fright about tuberculosis. MDR, TB, XDR, etc. became a reality. However, there was a silver lining, that there was availability of the cartridge-based PCR tests, like the Gene Expert, which is very popularly used now, the LPA and other pyrosequencing. So seeing these changing trends in the presentation and management of tuberculosis prompted me to collect the data on patients that I was treating for a long period of time from 2011, and I came across and treated about 237 patients of infective spondylodiscitis, and these exclude the patients who were already diagnosed with things like pyogenic or other fungal infections. Empirical treatment of tuberculosis is like a banned thing. It is not to be spoken about. However, there were some patients who were empirically treated for different reasons, like lesion too small to be biopsied, patient too morbid to be taken around for investigations by the relatives, early COVID time. But in most of the cases, the cause was that the tuberculosis treatment was started by the previously treating doctors. And since they had presented to me after a time of 6 to 8 weeks and they were doing well, I did not tinker with their treatment, and I let them continue the treatment. Leaving those 65 patients empirically treated, I had 172 completely diagnostically worked up patients, of whom 60% were females. The majority of the patients happened to be in the productive age group of 30 to 60 years. Dorsal spine was the maximum level of incidence. Amongst the junctional areas, the lumbosacral junction was having the highest incidence. So after a clinical and radiological suspicion of tuberculosis in those patients, and if surgery was not indicated, running the diagnostic test was the first and the foremost step to be taken. And the strategy was that to look for an abscess pocket. If there is the smallest amount of pus pocket available, then the strategy was to do an aspiration of the pus using under IITV, USG or CT guidance. And if that was not the case, then a biopsy from the vertebral body was planned. So in those cases where pedicular biopsy was planned, it was necessary to have the lesion in the upper half of the vertebral body in the lateral part of the pedicle, so that these lesions could be accessed from the pedicle. If that was the case, then I did a transpedicular biopsy under local anesthesia, under C-arm guidance, using my scoop technique. And if that was not the case, if the lesion was not accessible via the pedicle, then a CT guided biopsy was planned. So for pus aspiration under guidance, I would give some examples. If the abscess was located posteriorly in the psoas or the paraspinous region, or for anterior cervical abscesses, I would do them under IITB guidance using MRI images as a plotting device. And for psoas and iliacus abscesses not accessible from the posterior side, USG guided biopsy was aspiration was done. For example, on this MRI, you can see that the tuberculosis infection is at the D12L1 level, and there's a large pus pocket located on the left paraspinous region, but it is at L23 level. And as we know that the MRI provides us with a scale. Using this scale as to measure these images, you can measure the exact location of the abscess in the mediolateral plane, in the craniocaudal plane, as well as measure the exact depth of this pus pocket. You can then translate these parameters onto the patient using C-arm guidance. And once you have located the point where you are likely to get the abscess at a particular depth that you now know, you use C-arm guidance and insert the needle to that level and aspirate that pus. Similarly, for anterior cervical abscesses, the technique was to use the traditional Smith-Robinson approach as the direction for putting a needle. As you can see in this patient, there's a pus at the C7 level, which is aspirated using the C-arm and the MRI images as guidance. Similarly, this is a patient of C1, C2 tuberculosis infection who has pus pocket in the paraspinous region, and using these images and the techniques described, you can aspirate the pus from here. Now, if those methods and pus is not available, then transperical biopsy for the lesions which are located on the image shown is the next choice procedure. Many techniques have been described, and traditionally a J needle has been used. But here I describe a technique which I have developed and I use. It is called the scoop technique, in which essentially the point is that the posterior wall of the pedicle, from where we enter the pedicle, is usually very hard, and perforating that using a J needle can sometimes be difficult. Again, you also have to find the exact location of the tissue on which side of the vertebral body to decide from where to take the biopsy. For example, if there is a D6-7 involvement, then the lower vertebra, the D7 lesion, is closer to the disc space and right in front of the pedicle. So you choose the D7 level, and the side of the pedicle is decided on the axial images. For example, on this image, you can see the left D7 pedicle has a significant amount of diseased tissue which you can take for biopsy. So the patient is placed prone without any bolsters, because bolsters can make them uncomfortable. And this is done under local anesthesia. Initially, you make a skin marking for the stab incision you would like to take. After preparation and draping, a subperiosteal infiltration and infiltration of the tract, subperiosteal infiltration of the pedicle and the surrounding area, and of the tract is done. And then, after that, you make a stab incision at the marked site. You place a 3 mm K wire just 1 mm lateral to the center of the pedicle. Anchor with pressure and attach a T handle. View on the lateral view the accuracy of your placement. Sometimes the pedicle can be really hard, and I have often used drill to negotiate the posterior wall. The wire is then advanced to about 2 centimeters inside the vertebral body, and then a slightly angled scoop is advanced through the pedicle, through the perforation in the pedicle into the vertebral body to the desired depth. Again, verification of the scoop is done on the C-arm, and then using pressure on the cup side of the scoop, you can remove tissue, the diagnostic tissue from the pedicle. And the advantage of this is that the scoop can be rotated through 360 degrees, giving you an access of almost about 9 to 10 millimeters through which you can from where you can take biopsy material, and this can enhance the tissue retrieval. Multiple chunks of bone can be removed by this technique, and usually 3 to 4 each for histopathology and microbiology are taken. Total of 80 such procedures were performed. There were no complications of this procedure. The advantage is larger radius of accessibility, greater tissue variability, but the disadvantage is that you have to insert the scoop several times in order to retrieve more material. Now, out of the 172 patients, 72 underwent aspiration, 80 underwent transpedicular C-arm guided biopsies, and 20 patients were subjected to other biopsies, USG and CT guided. The samples were sent, all samples were sent for microbial testing, including gram stain culture, acid-fast bacilli culture, gene expert fungal stain and culture, and the bone samples were sent for histopathology as well. Now, coming to the yield of the individual tests in the two groups, you can see that in the transpedicular biopsy group, there were 80 patients. Now, 14 patients were done before the advent of gene expert. So, those patients could not be could not undergo gene expert testing. Among the remaining 66, 36% patients were gene expert positive. The paucibacillary nature of the disease is known, and only 4% were AFB positive, but the histopathology yield was significant, close to 50%, and the culture yield was about 31% only. Now coming to the aspiration group, out of the 72 patients, 15 patients did not undergo gene expert. Out of the remaining 57, 48 patients or 84% turned positive on gene expert. The AFB detection rate was low, but double than that of the transpedicular biopsy group. And the culture yield was almost 3/4 of the patient had a positive culture. Now, for the cumulative yield of totally how many patients were diagnosed based on these tests, if you take the transpedicular biopsy group, out of the 80 patients, 24 were gene expert positive. Of the remaining, 20% yielded positive results on HP and AFB, and 3% patients on culture, giving a total yield of about 66%. Now, if you look at the aspiration group, there were 72 patients, out of whom 75% were positive on gene expert, additional yield of 1 from acid-fast AFB stain, and additional 14 patients were culture positive, giving a total yield of 87% patients diagnosed positive based on the pus assessment. Now we saw that there were some patients who were done in the pre-gene expert era. So if I compare the two groups, for the biopsy group, the yield before the gene expert era was 57%, which increased by 19% to 68%. Whereas in the aspiration group, the yield was 80%, which increased by 12% to 89%. So in addition to giving early diagnosis and status of rifampicin resistance, the yield of diagnosis is considerably improved by the advent of gene expert. Now, all patients did not show all tests positive, and in the biopsy group, 65% patients had 2 or more tests positive, whereas in the aspiration group, 70% of the patients had 2 or more tests positive. But the important thing to note is that biopsy group, 27% patients still remained undiagnosed, as opposed to 10 in the aspiration group. Sensitivity of gene expert with respect to the gold standard of MGIT showed that 92% of the aspiration group patients were sensitive. Amongst the biopsy group, the average sensitivity was about 71 to 73%, where the transpedicular biopsy is taken alone or all the biopsy patients are taken together. It's noteworthy that the specificity of the aspiration samples was much low as compared to the biopsy group, where the biopsy group specificity was in the 80s. The aspiration group specificity is only about 37%. The PPV and the NPV reflected respectively sensitivity and specificity. Now, the low specificity of aspiration group can be attributed to the fact that the pus may contain a large number of dead bacilli, giving rise to many positive results. But the inference of this can be based on the history of prior treatment. If prior treatment was taken, then this would not be a true reflection. But if prior treatment is not taken, then this definitely can be taken as diagnosis of tuberculosis. In the biopsy group, the sensitivity was lower, but the specificity was higher, which indicates that usually the bacteria that are detected in the biopsy are usually live bacteria, which rarely give false negative results. So if you want to compare pus and bone biopsy, I would say that pus is like a flamboyant student who is super intelligent and knows a lot of stuff. He's highly sensitive, but he's a calculated bluffer because he can use his skills to bluff and get away. Whereas a moderately intelligent student he knows a lot of stuff, but not as much as super intelligent guy. So he is reasonably sensitive, but he's bad at bluffing. So he's highly specific and gets good marks. But usually the super intelligent guy takes the cake. Out of the 172 samples, 92 came positive on culture, 87 underwent drug sensitivity testing, and drug sensitivity testing based on LPA was available for 2 patients, giving total 89 patients for whom we had drug sensitivity results. The number of drugs tested varied depending on the situation. However, a significantly large number of patients underwent 13 or more drug testing, and there was resistance to 1 or more drugs in 1/3 of the patients. Out of these 29, 28 also showed drug to 1 or more primary drugs. So almost you can say all of the patients are having some or the other primary drug resistance at the time of detection in 33% of the cases. How many drugs patient was resistant to? The patient were, that also the varied number of patients, but it is noteworthy that a large number of patients also had resistance to 5 or more drugs, as you can see from the table. Individual drugs consideration shows that in the primary drugs, all drugs show resistance in significant numbers, and INH is the maximum, rifampicin is the next. So these two commonly used drugs are showing high levels of resistance. In the quinolones, Oflox and low dose moxifloxacin showed significant resistance, whereas the high dose moxifloxacin and levofloxacin showed lowest resistance. But only of late, the testing of moxifloxacin high dose and levoflox has been started. So the number of patients is small, so still this result cannot be considered as a very valid result. In the second line injectables, amikacin, kanamycin, capreomycin showed low resistance levels, and streptomycin, which showed high resistance, is presently not considered an AKT drug. And amongst the other second line drugs, linezolid, clofazimine and PAS showed lower resistance levels as compared to ethionamide. Now if we go by the WHO classification of drug resistance, rifampicin resistant tuberculosis was found in about 18% of the patients. Now as of today, INH resistance is considered as a surrogate, the rifampicin resistance is considered as a surrogate marker for INH resistance as well. So mostly people feel that RRTB should be labeled as a MDRTB. So you can say that this percentage represents MDRTB. About 11% patients had monoresistant to one of the primary drugs, polyresistant to primary drugs, 3 patients. MDR-TB incidence was about 15 patients, that is 17%, close to 17% of the patients showed MDR-TB, and pre-XDR and XDR-TB, which are actually subsets of the MDR-TB, also showed significant numbers, with XDR-TB being present in 9 out of the 92 samples that were tested. Gene expert is now considered a very, very important test in evaluation of tuberculosis, and the sensitivity of gene expert as compared to the golden standard MGIT is 91.67% in these cases. It also shows high specificity of 98.21% and similar reflection in PPV and NPV. So gene expert presently can be considered at par with culture, and the advantage being it gives early diagnosis as well as early rifampicin resistance and drug resistant indication. So drawing conclusions, it is a must to do diagnostic evaluation in all suspected cases of TB spine. Your best efforts are required to do this. A pus sample has higher diagnostic value than higher microbial value than a bone sample. Bone sample yield rests more on histopathology, which will definitely help you in concluding the diagnosis, but much less value in drug treatment planning because the culture rate is very low. If there is an option to do tests, always try to get a pus sample than a bone sample. MDR, pre-XDR and XDR-TB are frightening realities. 1 in 6 patients are likely to show MDR or XDR-TB. The cartridge-based polymerase chain reaction tests like the gene expert are offering a high benefit of early diagnosis, early resistance indication, then MGIT for M- with high sensitivity as compared to the MG, as compared to the drug resistance testing. TB is a medical disease and surgery cannot alone fight it. Making the right choices of AKT means more than half the battle won. Only a properly curated treatment based on evidence can help us out of this situation. And I hope you all have absorbed the information and concur with what I said, concur with all the information and messages that I conveyed. So my take now becomes our take. Thank you very much.